We have two resident presentations today. The first will be given by our night float extraordinaire, Jeffrey Carbonella. He is one of our PGY2 urology residents. And he actually was born at St. Raphael's Hospital. It's fondly known as the son of St. Raphael's amongst the department here. He has remained here in Connecticut for the majority of his life. He went to undergrad at the University at UConn, was contributing to Dan Hurley's new contract with the Lakers. When it came time for medical school, he studied at St. Louis University School of Medicine on full scholarship from the Air Force. And he's currently a captain in the Air Force and looking forward to his time as an Air Force urologist following graduation. In his free time, he enjoys running with his dog Arya, golfing, and cooking for friends and family. Jeffrey.
All right. Thank you for that wonderful introduction, Ben. So good morning, everyone. As Ben said, I'm Jeffrey Carbonella, one of the PGY2s here. And today I will be reviewing bladder neck contractures and their etiology and management. Just as a little outline, today I wanted to touch on the etiology of bladder neck contractures, the epidemiology and risk factors for developing bladder neck contractures, and then focus most of our time on the management options. All right. As far as disclosures, I have no disclosures. So to start, I wanted to review the definitions of bladder neck contracture and vesico-urethral anastomotic stenosis or stricture. These terms are often used interchangeably in the literature. However, it is more appropriate to refer to stenosis following prostatectomy as a vesico-urethral anastomotic stenosis, whereas stenoses after benign prostate procedures are referred to as bladder neck contractures. Bladder neck contractures can range in complexity from simple, short annular contractures to complete obliterative refractory to repeated interventions. The etiology, frequency, and complexity of bladder neck contractures varies depending on which treatment occurred prior to its development. So bladder neck contractures rarely occur secondary to trauma or idiopathically, and essentially only occur following prostate surgeries or, in the case of VUAS, secondary to prostatectomy. Now, theoretically, radiotherapy can cause bladder neck contracture, but in practice, radiation-induced strictures are typically seen at the membranous urethra, not at the bladder neck. At a cellular level, disordered collagen deposition and fibrosis at the bladder neck occurs secondary to microvascular changes, either from surgical factors like high heat resections or, again, theoretically from radiation therapy. And this scarring leads to narrowing or contracture of the bladder neck. So essentially what it all boils down to is alteration in blood flow or blood supply of the tissue at the bladder neck. As for the incidence of bladder neck contractures, this depends on the treatment modality that preceded its formation. So various papers exist that report different incidence rates following procedures, but generally the incidence rate of bladder neck contracture occurring after TURP is reported between 1 and 9%, HOLEP and THULEP around 2%, and green light PVP between 3 and 5%. For vesico-urethral anastomotic stenosis, as a complication of radical prostatectomy, this occurs at a rate of about 5% most of the time. And that's keeping in mind that that includes open radical prostatectomy and robotic radical prostatectomy. And we'll kind of get into differentiating those in a little bit. This graph here from Nagpal et al. Demonstrates the breakdown of 40 of their patients and their causes of bladder neck contracture. This was a systematic review done by Rosenbaum et al. And the authors here looked at the incidence of vesico-urethral anastomotic stenosis after open radical prostatectomy and robotic radical prostatectomy. And as you can see, open radical prostatectomy is associated with a significantly higher incidence of vesico-urethral anastomotic stenosis at 8%. And even if we exclude that outlier study reporting a 26% incidence, that rate only drops to 5.4%. And that's in contrast to robotic radical prostatectomy, which at least in this systematic review demonstrated a rate of on average 1.06% following robotic radical prostatectomy. This was a single institution study retrospectively done by Gobler et al. And they looked at patients undergoing primary TURP procedures and performed an analysis to identify possible risk factors for bladder neck contracture development. They had a patient cohort of 1,368. They were analyzed, and the authors reported that smaller preoperative prostate volume, lower resected prostate weight, lower preoperative PSA, shorter duration of the surgery, and secondary transurethral interventions, either due to urinary retention or gross hematuria during their index stay, as well as positive preoperative urine cultures, and then urethral stricture formation, particularly at the membranous or bulbar urethra, requiring a DVIU postoperatively after TURP. All of these aforementioned things are statistically significant risk factors for forming a bladder neck contracture. Another retrospective study, this was done by Grechenkov et al. Out of Russia, demonstrated slightly conflicting data for bladder neck contracture risk factors. And in this study, they found that an increased prostate volume rather than a small prostate volume pre-op was significantly associated with bladder neck contracture formation. And although this was a smaller study with only 106 patients meeting criteria for analysis, it does go to show that risk factors can vary. Another study here, this one was out of UCSF. They retrospectively reviewed their own institutional database to find patients that underwent RALP or open radical prostatectomy over a 6-year period, and performed analysis to evaluate associations of demographics and clinical characteristics with the development of bladder neck contracture. They report a lower than typical bladder neck contracture rate in radical prostatectomy patients. And the authors reported that the difference in rates of bladder neck contracture between open radical and robotic radical prostatectomies may be due to technical factors such as enhanced magnification using the robot and a running bladder anastomosis when performing robotic prostatectomies. Here we show a study done by our very own Dr. Kim during his time at Rutgers. The authors here analyzed a prospectively collected database of 930 patients who underwent RALP by a single surgeon over a 6-year period and found a 1.6% of incidence of bladder neck contractures over a median 2-year follow-up period. And the commonality noted between these patients was higher intraoperative blood loss than patients who did not go on to develop bladder neck contractures. And the authors theorize here that an anastomotic leak with prolonged urine leakage and therefore secondary or healing by secondary intention may increase scarring and contracture at the bladder neck. All right, so now that we discussed a little bit about the risk factors, how do we actually make the diagnosis? So typically patients will present complaining of weak urinary stream or prolonged unexplained incontinence approximately 6 months following their prostate procedure. The top picture here is of a retrograde cystourethropy demonstrating a bladder neck contracture, and this is the gold standard diagnostic test. Other common presenting symptoms would be frequent urinary tract infections following their procedure. Now a little bit on the guidelines for management. So this is where we'll spend the remainder of the talk. The AUA states 3 guidelines. We have statement 27. It states that you can treat bladder neck contractures with dilation, bladder neck incision, or transurethral resection after an endoscopic prostate procedure. And this is expert opinion only. Statement 28 states that these same techniques can be used for a post-prostatectomy vesicourethral anastomotic stenosis. And this is a conditional recommendation, grade C. And then statement 29 states that robotic or open reconstruction of recalcitrant stenosis can be done for vesicourethral anastomotic stenosis. And again, this too is a conditional recommendation only. Here, I just wanted to display a decision tree that outlines the varying guidelines from the AUA, the SIU, and the EUA. The AUA, in their discussion of guideline statement 27, states that treatment of bladder neck contractures following endoscopic prostate procedures can be performed with either a bladder neck incision or bladder neck resection, depending on surgeon preference. We can expect comparable outcomes with both of those procedures. Repeat endoscopic treatment may be necessary for successful outcomes, and per the AUA, there are no studies that exist that compare the different treatment strategies for bladder neck contractures, like head to head, after an endoscopic prostate procedure. Another decision tree here demonstrating the complexity and variety of options for treatment of bladder neck contractures. And you can see a number of failure outcomes and secondary recommendations. In the discussion of guideline statement 28, the AUA states that treatment of first-time vesicourethral anastomotic stenosis is successful in about 50 to 80% of cases, with all techniques having similar rates of success. It's very important that patients should be made aware of the risk of incontinence after any of these procedures. And one last treatment algorithm, this is specifically for vesicourethral anastomotic stenosis, again demonstrating the array of treatment options, many secondary to double failure of dilation, incision, or resection, and subsequent repeat procedures. In their discussion of guideline statement 29, the AUA states that the treatment of recalcitrant vesicourethral anastomotic stenosis or bladder neck contracture is challenging and may cause significant urinary incontinence requiring subsequent artificial urinary sphincter implantation. And in regards to robotic versus open technique, the AUA cites that robotic assisted reconstruction patency rates range from 73 to 75%, and open vesicourethral anastomotic stenosis or bladder neck reconstruction can be performed retropubically or perineally with patency rates ranging from 70 to 100%. And it's also important to note that these success rates are often much lower if a patient's had radiation therapy prior. All right, so let's follow our decision tree and take a look at the data in the literature. So starting off, urethral dilation is commonly recommended as the initial step in bladder neck contracture management. It has a high success rate of greater than 90%. However, the pitfall of dilation is that it requires patient adherence and cooperation with self-dilation. And as we all know, self-dilation can be, poor patient quality of life impact, and therefore it's often not tolerated by many patients. This brings us to our next most common first-line treatment, and that is incision, so transurethral incisions to the bladder neck. This is also recommended as an initial management step with or without adjuvants, which we'll discuss in a little bit. The success rate here ranges from 72 to 91% in these three studies, with the big difference being just where the incisions are made. So this is often just provider preference. So for example, in the study from Cow et al., they made incisions at the 5, 7, and 12 o'clock positions. And they also note in these studies a few patient factors. So smoking and then 2 or more prior transurethral bladder neck incisions were significant risk factors for failure. The complications here were minimal, but 9% of patients required a repeat transurethral incision in the Cow study. Here, I just wanted to show a few images of a transurethral incision. This is from that Cow et al. Study. So A through D demonstrate incisions made with a needle electrode from the bladder neck to the proximal verumontanum, and these were all reaching down to the adipose layer. In panel E, we demonstrate the immediate resectoscopic view of the bladder neck after a transurethral incision. And panel F is the cystoscopic view of the bladder neck 1 month after a transurethral incision. You can see pretty nice patency there. So now I just want to discuss a little bit about the adjuvants with injections. So mitomycin C and triamcinolone alone have been injected into the scarred area, generally after incision or dilation, and are thought to prevent rescarring of the tissue. This is generally used for patients who have failed incision or dilation alone, and the success rate is generally reported to be about 72 to 83%, but these are all very small powered studies. All of these studies shown above have used injectables in combination with bladder neck incisions, and multiple injections may be needed in order to achieve durable patency. And although rare, the complications noted in these studies are quite serious, so there's something to be aware of. And they included anaphylaxis, bladder neck necrosis, and rectourethral fistula development. A lot of them note that it's very important to not make an incision at the 6 o'clock position for that very reason. So when we perform incisions incisions with mitomycin C injection here with Dr. Cavallo, we make a cold knife incision in a tri or quadrant pattern, and we typically inject 0.3 to 0.4 milligrams of mitomycin C at each site. A newer technique that I wanted to talk about is transurethral incision with transverse mucosal realignment. This is something that we're doing here with Dr. Sterling. This has been suggested as a treatment option after multiple failed endoscopic incisions or injections, incisions with injections, and for those who are unable to tolerate intermittent self-catheterization or more invasive operative approaches. So there's really only one main paper here, and it's by Abramowitz et al. Describing this technique. They had 19 patients, 89% of whom were reported to be successful. And that was defined as the ability to pass a 17 French cystoscope at the 4-month point after one procedure, and they noted 100% success. Patients were patent after 2 procedures. However, these patients did not have any previous dilations or bladder neck incisions, and thus, we're unable to tell if they would have been successful with more common treatment routes alone. And then it's important to note that the complications in this study were very minimal. So this is a little slide just showing the J&W Urethral device that is used for what is affectionately coined Twitmer. So the device here includes a multi-purpose 26 French sheath with a dual 3 and 5 millimeter working channel, and that allows for the simultaneous passage of an imaging scope. Here we use a ureteroscope and the suturing device that comes along with it, which they coined the RD180. So if this works, it's just a quick little clip of a Twitmer. And then I'll kind of just talk a little bit about what the procedure entails. So we use that 26 French continuous flow cystoscope with a visual obturator first to just inspect the urethra. Sensor wire gets passed then through the stricture, and the cystoscope is then exchanged for a work, the visual obturator exchanged for a working element, and then needle tip electrode is used. In vesco-urethral anastomotic stenosis, they make an incision at the 3 and 9 o'clock positions, opening until they're, we estimate about 30 French. And then in bladder neck contractures, the incision is made down into the fat plane. We leave that outer sheath in place, and the inner lumen and working element are removed. And then through the outer sheath, a 5 French ureteroscope and the RD180 are able to be simultaneously passed down the channels into the bladder. They use pressure flow for this because a lot of the irrigant is lost, and that's important for visualization. And that RD180 is then used to grasp the mid aspect of the proximal edge of the bladder mucosa. And then we've also next we'll thread a suture through the 1 millimeter and 1 by 2 millimeter titanium tie knot, and this gets secured into position using that RD180 device. And basically, it pulls that bladder mucosa distally to realign the urethral mucosa, and then this is repeated for each incision point. And then at the conclusion of the procedure, we leave a catheter in place. And then patients are seen post-operatively for a cystoscopy in the office to evaluate for patency. The last 2 treatment options that we'll talk about are robotic and open reconstruction. And there are 3 reported approaches for open reconstruction. That's abdominal perineal, and transpubic. The robotic approach mirrors that of the port placements for a prostatectomy. And then just wanted to discuss each of those in a little bit more detail. So robotic and open reconstruction should be considered for patients with recalcitrant bladder neck contractures. So they've undergone multiple other procedures and have had recurrent failures. There are still no large scale series to describe the outcomes of these procedures, but 2 studies do demonstrate success. The Shamat study reported 100% success after open YV plasty reconstruction. And this success was defined as no need for further instrumentation, such as indwelling catheterization, urethral dilation, urethrotomy, or surgery in their 18-patient cohort. And then this Graneri et al. Study reported 100% success after a robotic YV plasty reconstruction, and they defined their success as the absence of infections, symptoms, and cystoscopic evaluation in their 7-patient cohort. So both of these papers state that they feel the keys to success are adequate excision of scar tissue and a tension-free anastomosis with good apposition of the mucosa. So this was from that Shamat et al. Paper, and where they performed open reconstructions with a YV plasty. And essentially, the procedure is as follows. So they make a lower midline laparotomy, and an extraperitoneal approach to the dissection of the bladder is performed. After proper exposure of the bladder neck, the anterior bladder wall is incised through all tissue layers in a V-shaped manner, forming a well-vascularized anterior bladder wall flap. The scar tissue at the bladder neck anteriorly is excised, and then an incision is extended down at the 12 o'clock position until the tissue is freely movable and palpable of scar or rigidity. But this is important that this remains proximal to the external sphincter. And this is what creates that Y limb of the YV plasty. Then next, an incision is made at the 6 o'clock position. And this is with or without excision of scar tissue to ensure that the bladder neck is opened posteriorly and a catheter can easily be passed into the bladder. The bladder flap is then parachuted to reconstruct the anterior wall of the prostatic fossa and bladder neck, and a leak test is performed to ensure a watertight closure, and then pelvic drains are routinely placed in this procedure.
You point out for just a minute,
Yes.
like the Y and the V, like just.
It is hard to see in this picture, but here's where they're drawing out their V portion. Oh, you can't see my. Yeah. So on this, here's their V portion, and then they carry this down at the 12 o'clock position to make the Y limb. The next slide actually has a little bit of a graphic that might be a little bit easier to understand. It is, it took me a few times to understand it myself looking at this, but here the robotic approach is, it essentially mirrors the open approach. Ports are placed as they would be again for a robotic prostatectomy. And there are a number of very helpful videos on the AUA website that demonstrate the technique. However, in the interest of time, I opted to include this graphic instead. But I did find them very useful. Some of the potential benefits of the robotic approach over the open approach are potential preservation of continence, no resection of the pubis, and then ability to be done as an outpatient surgery. All right, as you can see, there are many risk factors for the development of bladder neck contracture and vesicourethral anastomotic stenosis that are theorized, but more study can be done on how to optimize procedural interventions to reduce the occurrence of these complications in the first place. And then additionally, there are very few large cohort studies that compare treatment options among similar patients, and long-term follow-up studies still need to be done. There's increased application for the use of MRI in the diagnostic workup of stenosis, and this is to hopefully better classify the severity and complexity of the stenosis prior to the initial intervention. And then in summary, there is no standard treatment approach And more prospective multi-institutional studies are needed to better inform our treatment options. And for now, there are many tools that appear to have good outcomes, and we should be familiar and comfortable with all of them.
All right, good morning. So thanks for having me. My talk today will be on urethral bulking agents, and the title is to bulk or not to bulk. That is the question. I have no disclosures. My agenda for today, I'll start by kind of doing an overview of stress urinary incontinence, going through the historical treatments that have been available, and then kind of diving into the bulking agents specifically. Bulkamid would be kind of the focus of this talk because that's the one that I've had the most experience with lately and is now kind of the newest kid on the market, so to speak. And then my primary question or things that I really wanted to evaluate for this was to think about who are the patients that should be receiving this treatment. And then just kind of briefly touching on future directions and like questions that are ongoing in the field. So stress urinary incontinence is the involuntary loss of urine associated with increases in abdominal pressure. And this can occur during or after things like lifting, physical exertion, sneezing, coughing, laughing, sexual activity, or any other activities that increase the intra-abdominal pressure. And this is a very distinct entity from urgency urinary incontinence, which is the loss of urine associated with urinary urgency and frequency. And this is a definition provided in the AUA guidelines. The pathophysiology is not 100% understood, but there are two main kind of theories or components as to what leads to this. The first is urethral hypermobility, and the idea is that the urethra is normally supported by like a hammock, so to speak, by its anatomical support system, which is composed of the pubourethral ligament and the endopelvic fascia. And whenever this support is compromised in any way, the urethra then becomes hypermobile, and it does not allow for appropriate transmission of pressure from the abdomen to the urethra, so you get leakage. The other idea is intrinsic sphincter deficiency, which is where the urethra's kind of watertight outlet is compromised, and it's no longer watertight. And again, this has to do with the loss of the anatomic support, but the urethra in this case can be either hypermobile or fixed. If you do a UDS in these patients, the definition specifically is a valsalva leak point pressure of less than 60. So the risk factors for stress urinary incontinence include higher parity, and here it's more of like trauma associated with childbirth, and then increase in age, which is thought to be due to potentially, at least partially, the loss of estrogen over time, the Caucasian race, smoking, lung disease, and obesity, which more have to do with kind of chronic intra-abdominal pressure conditions. So the guidelines are straightforward in terms of how to evaluate these patients up front. You start with a history and physical, and you want to demonstrate stress urinary incontinence objectively. So this can be easily done by having your patients come into clinic with a full bladder and then have them cough or bear down. In clinic, this is not, it can be very, very clear in that you can pretty much get hit with urine in some of these women. So it can be very clearly objectively identified. And that's why this is one of the preferred ways to assess them. You also want to get a PVR and a UA to evaluate for any other conditions that may cause incontinence. So in the standard or your index patients, cystoscopy and UDS is not necessary, but there may be times in which these and other evaluations are necessary. So if you're suspecting that patients potentially having any kind of neurogenic lower urinary tract issues, or if you can't demonstrate SUI on a simple exam, if their UA is abnormal, like microscopic hematuria, or they have signs of infection, if they have mixed urinary incontinence, which is a component of both kind of urgency, but also stress, and you want to define that a little bit better, you could do this, a cysto or UDS. And then if they have elevated PVRs, incomplete MTN, if they have prolapse or any other signs of significant void and dysfunction. So treatment can be non-surgical and surgical. Non-surgical includes your pessaries, your vaginal inserts, and then your pelvic floor physical muscle exercises with or without biofeedback. But the focus today is looking at surgical management, which the gold standard really is the sling, in terms of how frequently it's used and the efficacy and the outcomes. But other options include autologous fascial pubovaginal sling. And I've heard this a million times, but I've never actually seen it because it's kind of fallen out of favor. But birch copal suspension was pretty popular back in the day. And then lately, Bulkamid agents have certainly made their mark. So the historical treatments, so the pubovaginal sling actually was initially described in 1907. It was made with gracilis, and then later on, the pyramidalis muscle was used. And then they developed the fasciolata sling in 1933. And then finally, Aldrich developed the used rectus sheath as pubovaginal sling. And the idea here is to support the urethra and kind of replace that anatomic support that it normally has that has been lost. Other techniques, so anterior corporaphy, which was a technique that was developed to address both anterior prolapse as well as stress urinary incontinence, and you expose the bladder neck by making an incision into the vaginal wall, and then you do mattress sutures securing it to the endopelvic fascia. In 1949, urethropexy was developed, and this was a trans-abdominal suspension technique where, again, you expose the bladder neck and you secure it with sutures to the periosteum of the pubic symphysis. Later on, the needle suspension technique, which is where you made 2 incisions, one in the vagina and one in the suprapubic, and you essentially pass some sutures to the endopelvic fascia on either side of the bladder neck through the spates and restius, and you secure that to the rectus fascia. And then birch copal suspension. This is again where the bladder neck and the proximal urethra are supported or suspended along the ipsilateral pectineal, pectineal or Cooper's ligaments on the pelvic side wall, as shown here. Later on, the mesh slings essentially were developed, and this is where this is positioned at the mid-urethra. And then this was 1995, and then the transoperated technique came about. And this was developed to try to avoid that blind passage into the retropubic space. And this brings us into Bulkamid agents. So the idea behind Bulkamid agents, again, is to you inject material essentially into the wall of the urethra, and you're trying to allow for that watertight outlet to actually be watertight, and you're trying to do that by coaptation of the urethra. So you're trying to really close that space. So this was initially described in 1930s. They used like really crazy materials to develop at first. So they had sodium morate, wax, sclerosing agents, and the idea was to kind of create a scar around the urethra to act as like a way to support it. And then they had a ton of reactions. Patients didn't do well. So they thought maybe if we just injected autologous fat around it, maybe this would have better outcomes, but it didn't. They had poor outcomes and complications. They tried Teflon, and this was not approved because it migrated to different areas and caused a lot of complications in patients. And then they had hopes for 2. This was Tigres and Deflux. So Tigres is made out of ethylene vinyl alcohol. It was actually very efficacious in reducing stress urinary incontinence, but it led to a ton of urethral erosions in these patients, up to the order of 37%. So it was never approved. And then many of us in this room know of Deflux, and it's used in vesicourethral reflux. When they tried it for stress urinary incontinence, it didn't work, and it actually led to the development of these sterile pseudoabscesses. And lastly, contingin, which is bovine collagen, was studied, and it was actually pretty safe in terms of complication rates, but it wasn't as efficacious. So they now use it as like a control arm to evaluate other Bulkamid agents. So what did we learn from the past? Essentially, you want an agent, obviously, that is going to stay where you inject it. So you want it to be non-reabsorbable, and you don't want it to create a significant inflammatory reaction in your patient population. So you want it to be non-immunogenic, non-allergenic, and be biocompatible. So what's currently out there? So a lot of these, honestly, I've never heard about, but in doing this review, and that's because a lot of them over time have fallen out of favor. So Duratosphere, this was developed by Boston Sci. This is made out of zirconium beads suspended in water. Take note of the size of the beads. This was approved for stress urinary incontinence, specifically due to intrinsic sphincter deficiency. And the thought here, or the advantage here, was that because the beads are large, maybe they won't migrate or move. But they later on found that it did some move, at times can migrate into the lymphatics. And the efficacy initially was good, 80.3%. But then when they did extended follow-up at 24 and 36 months, it dropped to 33% and 21%. The complications are relatively low. Patients had periurethral mass formations and urethral prolapse. This one I kind of heard about, that microplastique. This was a non-biodegradable hydrogel containing silicone that was suspended in water-soluble gel. And the particles here had a larger range size from 50 to 400. The efficacy rate was 61.5% at 12 months. But because they had those smaller sizes of the beads, the patients did have issues here with migration over time. And then this was Coaptite. This was developed by Boston Sci. And this was made of calcium hydroxyapatite, which is a substance that's found in your teeth. So it's actually radiopaque, as demonstrated by the image to your right below. And initially, the bulking is provided by that gel, but then it would dissolve. And then it's really the tissue that would ingrow around the calcium hydroxyapatite that would provide the support in the long term. Efficacy rate was about 63.4%, so not bad. But the actual substance, like the calcium hydroxyapatite, led to some vaginal erosion, and urethral prolapse in this patient population. So finally, we get to Bulkamid. This is like the newest kid on the block. It's the only one I've used in my training. This is a non-biodegradable hydrogel, and this is made of cross-linked polyacrylamide and water. This was approved in 2020, and you can inject it either through a regular cystoscope, but most people use the proprietary urethral developed by Bulkamid. So this is the setup. Can I like move the mouse? Or is it gonna, okay. Okay, perfect. So this is the rotating urethral, the sheath, and the needle can go in here. These are the 23 gauge needles. This is a syringe with the Bulkamid in it. And this is the urethroscope, which is 11 centimeters long. It's a 0-degree lens. And this is what a setup should look like when done appropriately. So unlike other, like for example, cystoscopes, you don't rotate the light, you just rotate the sheath into the areas that you want to inject. So on their website, they gave us this really cute diagram kind of comparing Bulkamid to slings. Even by their own reported numbers, clearly Bulkamid compared to the slings is not as efficacious. So we're talking objectively for the sling, 95% dry, and Bulkamid is 66% dry. Decent patient satisfaction, and then subjectively, quote, cured or improved at 92%. But if you look at the sling slide, objectively, patients are much happier with the sling, but the biggest thing they're highlighting here is the complication rate. So patients have a higher complication rate with slings. This includes tape erosion, chronic pain, difficulty emptying their bladder, tape protrusions, etc. And I'm assuming this is purely with the mesh slings and not really addressing pubovaginal slings, because I really haven't seen any issues like that with these. So even by their own admission, this is just not as good. So why would you even do this in the first place? So I wanted to see what the studies, their outcomes were in terms of Bulkamid. So this was an open multi-center study of polyacrylamide hydrogel for stress. And in this study, they included mixed urinary incontinence. Study had about 135 women with stress urinary incontinence or mixed. Keep in mind, one of the things that is often talked about with Bulkamid is that it does require reinjections. So in this study, the reinjection rate was 35%. Efficacy was defined at 1 month at 87%, but dropped to 66 at the 12-month mark. They also looked at some overall kind of incontinence questionnaires. And so as you can see here for the study, one question they asked is how often did you leak urine? And it was on a range of 0 to 5 per day. At baseline, it was 4. It was 4, and then at 12 months, it dropped to 2, so about a 50% reduction. So decently efficacious, but did it hold up over time? This was one study looking at the 7-year efficacy and safety outcomes of Bulkamid for patients with stress. Their primary endpoint here was patient satisfaction. The cured and improved rate was 67.1% if Bulkamid was used as a primary procedure. And this was a bit lower in the patient population that used it as a secondary procedure. So 61.4%, for example. They also had secondary endpoints. And one thing that I was very curious about was the pad usage. So at baseline, for the patients who used it as a primary endpoint, as shown here, they were using about 4.2 pads per day. And then at the 7-year mark, they had dropped to 1.8%. So these were significant. And I think from a quality of life standpoint was really important to see this result. But I was also curious about the complication rate. And the reason I went through showing you the other bulking agents is they fell out of favor due to the complication rate. So I was curious to see if over time at the 7-year mark, for example, what would be the complication rate seen with Bulkamid? And surprisingly, and I think a very good thing, is that over time, you're not really seeing any complication rate like erosions or migration of the substance when injected. You're really seeing complications as demonstrated here in this study of things associated with standard cystoscopic procedures, like maybe temporarily having prolonged emptying time or UTIs and things like that. So I think from a complication standpoint, this seems to be holding up a lot better than the other ones used before. So, I mean, they've already shown it on their website by the diagram I showed you, but just wanted to take a study to kind of look at the efficacy of Bulkamid compared to, in this study, they looked at slings. So that they had 224 women with stress urinary incontinence in Finland, and they had failed pelvic floor physical therapy. And they randomized them in a 1-to-1 study with sling, and then they kind of looked at and evaluated using like quality of life questionnaires and like validated questionnaires like the UDI-6, for example. And they collected data preoperative compared to the 1-year mark, and just very straightforward, just even with this diagram. You can see preoperatively in black is the sling, pretty elevated here, but then after the sling, a pretty significant drop in UDI-6. So from an incontinence standpoint, patients saw a significant reduction. And then this gray is demonstrated your Bulkamid, and you do see a drop at the 1-year mark, but comparatively, it's a lot lower than, the drop is not as significant compared to the sling. So overall, yes, there's improvement that's significant for the patients, I think both statistically, but also like actually real life and clinically, but it is definitely not as good subjectively or objectively in terms of efficacy. So diving into patient selection, who should get this, when, why, how, etc. So just doing a lit review, it's recommended, people had their own kind of clinical recommendations. So one that was clear and consistent is that this is a good thing to do for patients with intrinsic sphincter deficiency. And again, it's because you're really helping with that coaptation of the urethra. But things that standard surgical things to think about, if your patient can't tolerate anesthesia, for example, this would be a good option because these patients, you can do this in clinic with local anesthesia. They don't have to go to the OR. We do send them to OR here. And then if a patient, for example, is not finished with childbearing and they want to have more children in the future, maybe you don't want to start with a sling. Maybe you can start with this. And if their incontinence is cured, then great. But if it recurs, then they can do a sling later on. If they're on active anticoagulation, they recently got a stent, you can't really hold it. This would be a better option than a sling, less bleeding risk. And then one of the big things from reading and just talking to people, a lot of times patients just want a less invasive procedure. If you don't have to proceed to the OR, you don't have to get a large incision. This would be a really good option for those patients. And then other things to think about. So one author recommended making sure that the urethral mucosa has pretty good blood supply, that the patients have a good estrogen effect. So maybe put them on vaginal estrogen before you do this procedure. And then lastly, you don't want to take a patient to the OR to get this done if they have any kind of pathology, like a urethral diverticulum or foreign body or anything like that. The guidelines provide very little in terms of guiding you in determining who should get bulking agents. So for your index patient, it is listed as just, one of the options. And then in the special cases category where they define this as stress with a fixed and immobile urethra, it is again just listed as one of the options. But there's no clear guides in terms of determining who should get the bulking agents versus something else. So one study tried to kind of look at that. So the initial study was a randomized 33-center study of Bulkamid versus contingent, and that's that control substance that I was mentioning earlier. The patients initially 345, but then it went down to 291 that were randomized. And at the 1-year mark, the cure rate in the study was 25%. And then they did a post-hoc analysis looking at that cured group to figure out what were the patient factors associated with being cured with Bulkamid alone. And they found that patients who were 60 years or older with fewer than 2.5 daily episodes of stress urinary incontinence episodes was associated with a cure. So obviously this is not definitive enough to make this recommendation, but maybe this is something that can be used in guiding and counseling your patients in the future. So what about patients who've had a sling and they recur in terms of their stress? Could this be an option offered to those patients? So this study looked at that, and they had about 60 patients, and the time interval since their sling was about 18 months. And the cured rate at the 1-month mark was 56.7%, which dropped to 25.4% over time. And the improved rate was 58.2% at the 12-month as well. So it is an option that can be offered to patients who failed a sling, and you can still get cured or have significant improvement thereafter. And one thing I liked about this study is that they actually give a pretty good diagram or an ultrasound demonstrating why this might be beneficial after a sling. So a sling addresses the mid-urethra, whereas the Bulkamid addresses more the proximal urethra. So this was an ultrasound. This is the bladder, as you can see here. And these were the sites at which Bulkamid was injected. So it addresses more of the proximal urethra, whereas the sling, which was still kept in place in this patient, is more at the mid-urethral level. So you may be getting kind of like a double effect. And maybe patients, especially with ISD, I can see being benefiting from this. And then one question I had was, could this be an option for patients who've had previous radiation? That tends to be a group that can be very difficult to kind of deal with. And so this one study looked at that. They had 46 patients with severe stress urinary incontinence. This was a multi-study prospective study, and the average follow-up was about 12.4 months. So they had separated them into 2 groups. Group A had had prior radiation for gynecologic cancers, and Group B did not. The cure rate in Group A was 25% at that 12-month follow-up, and the cure rate for Group B was 36.4%. Both groups saw significant improvement in their incontinence, but there was still a statistically significant difference between the 2. So obviously a better cure rate if you've never had radiation, but the improvement in incontinence in the post-radiation group was still significant enough overall. And then the last question I had was really cost considerations. I guess going into this, I thought Bulkamid would be maybe a more cost-effective option, but this study looked at that and found that is not true. So they found that for mid-urethral slings, given the fact that it is a more definitive treatment overall, is has better cost effectiveness than the Bulkamid. And again, the Bulkamid unfortunately does require re-injections, which might explain the cost issue there. And then some of these patients go on to need a more definitive treatment after recurrence. So not as cost effective. So in summary, who should get Bulkamid and what would you say to your patient? So I would say overall, it's a safe, minimally invasive option for the treatment of both stress urinary incontinence and mixed urinary incontinence. It may be best in patients that are older with mild to moderate incontinence, has been shown in some studies to have effectiveness in mixed urinary incontinence as a salvage therapy and in patients who've had prior radiation, though obviously more studies are needed to really confirm this. And then, in terms of costs, because it's not the most definitive treatment, it is not the most overall cost effective, but can still be an option for patients if they so choose. And on their website for Bulkamid, they had this diagram up. And actually in the actual study that they're using in terms of their numbers, it wasn't Bulkamid, but just urethral agents in general. And it was basically, if you presented patients with all of the options that are available to them, what would they choose? And a lot of patients, 64% overall, would choose urethral bulking as their treatment of choice. And I thought this was interesting because I remember when I was interviewing at one of the fellowships locations, the second year said that she had trouble meeting her sling numbers, which was unbelievable to me. And the reason is her patient population, they're literally coming in and saying, I want Bulkamid, straight up. So for the first time, I was starting to see maybe some changes in the practice patterns for this because of this option that's available. And I was just very curious to see how in the end it will affect different volumes of surgical options that are available to patients.